So the title of my talk is how to demystify CTO PCI, my unanswered questions. Now, my disclosure is that I'm a non CTO operator. I've been doing PCI for 20 years, but I have not taken that paradigm shift to become a CTO operator. So just out of interest, I need to know, out of my interventional colleagues here, who is not a CTO operator, because if everybody is, then my talk is mute. So, I see a fair number of hands. Okay, so good. We have things that we can talk about. So, what are the hurdles to starting that I personally feel? Well, one is changing mindsets. We need to change the paradigm shift in the way we approach CTOs. We probably need to unlearn some old habits that we picked up along the way, adopt new planning and techniques, which hopefully we will see over the next 2 days. And also work outside our comfort zone for a while. We get comfortable doing what we do on a subcortical level at times. And I remember myself when I was a fellow, there were many times when you felt uncomfortable, but that's how you actually learn. And last but not least is remove the mystical and mysterious from what is an achievable learned skill set. So what did I do when I was training 20 years ago in Vancouver for a CTO? Well, I would use a single guide. I would imagine where the CTO course of the vessel is. I would try to wire lumen to lumen using the wires we had then, the intermediate, the standard wires, maybe a pilot or a choice PT. If I was unable to cross, I would stop. And if I crossed, I would normally do an injection and see. If I'm subintimal or there's a dissection or dye staining, I would stop. And if I did cross, I was within the lumen, then I would, dock my remove my over-the-wire balloon with a dock and finish the procedure. But things have changed from the old days where I trained. So I have 3 questions I wanted to ask. Why should we decide on a CTO intervention in the first place? And I think this is important, okay? And of course, if you look at the right side of the slide, we'll look at many things that all interventional cardiologists need to consider before they actually do an intervention. The second is when. When you decide that you could do CTO PCI versus send a patient for CABG. And previously this was the highest reason for referral to CABG. And you need to look at other important salient points. What about the non-CTO vessels? Is there left main disease? What is the syntax score? Is the EF normal or not? Is this a CTO post-bypass? So all these things need to be considered in the when. But last but not least, the most important thing is the how. How do I take the CTO that Dr. Haitham showed on the right of the screen and make it as straightforward as the proximal type A lesion in the RCA? Well, you need to look at the CTO from a different set of glasses. We need to look at the anatomy of the CTO and not merely his presence. And this is where the assessment of the CTO is important. Looking at the scores, looking at proximal and distal cap, things I learned, landing zones, look at the collaterals, the way you actually assess the collaterals by doing off-mag cines. And then once you've really assessed the anatomy well, decide on the complexity of the lesion and your approach. So the anatomy of the CTO is essential. Then vascular access and other basic tools. The issue of dual injections. You cannot track a CTO in the dock. Really need to know where you're going, and ipsilateral and contralateral guides are important. Which routes? The sheath size and length. What guides? We have downsized now to 6 French, but all my colleagues really need 7 or even 8 French guides for extra backup. The issue of guide catheter extensions, and shorter guides for retrograde. So all these things I need to learn when to use and how to use them. And as Haitham said, there's this new lingo, this new terminology that is Greek to me. All these acronyms that I need to understand, all these new techniques that I need to understand. So we really need to be able to learn the new terminologies and what they actually mean. It's like when you entered medical school for the first time and you had to learn all the Latin words in medicine. Good. Then the wires, and this is probably my biggest, faux pas. Is I'm lost in the maze. There are tens of wires, and I really need a way to simplify the utility of different wires for different tasks. And we need to get comfortable and confident using a specific wire. And when there are so many wires, you actually need to understand when and how to use them, and how does it feel in your hands. And then all these new terminologies of wire externalization and wire snaring. Why do you do it? How is it done? All these things. And I still believe simplicity is the mother of beauty. We really need to simplify, the plethora of wires and how to use them. Microcatheters. No CTO intervention is done without one. And what would be the appropriate choice for a specific anatomy? How do you manipulate? How do you advance? How do you remove? How do you wire? And I remember when I used to use the microcatheter, my hands were on the table. All my CTO colleagues, their hands are up. So even the stance, so you look at their hands, look at how they hold their body when you're actually doing the procedure. Single or double lumen, what's the lowest profile, different tips for different anatomies. All these things are part of my unanswered questions. And then the approach. Well, as a non-CTO operator, probably I would start with the antegrade approach. Retrograde for now to me would be something I would delay. But what are the appropriate antegrade approaches? And when do I abandon the procedure? When do I say, enough is enough? We always, as a non-CTO operator, when I'm subintimal, that's a big taboo. Okay, dye staining, dissections, where is the wire? What happens if we perforate? All these are questions that my CTO colleagues should actually help and help me with. And then once you cross stenting and sizing, okay, do we IVUS everything? Do we cover the entire length of the vessel? What if the stent is in the subintimal space, or your wire is partly in the subintimal space? That was something that as a non-CTO operator I was quite uncomfortable with. And last but not least, complications. The old adage when I was a fellow, the artery is blocked. If you try to do PCI, nothing wrong is going to happen. Well, that's far from the truth. There are unique complications that pertain to CTO intervention, and their detection and management is going to be essential if you're going to be a CTO operator. So we need new skill sets for dealing with perforations. What do we do with septal hematomas? Hemorrhage, because we have large bore catheters in, and dissections. Meticulous attention to detail to actually prevent complications, especially if the procedure drags on hours, at a time, which can happen sometimes. And this to me is probably the biggest deterrent, being able to deal with the complications. So that's actually my 10th question, and I will end with the poet Rumi, who said, when you ask, the answer will be given. And I hope that the questions I asked today will find answers from our esteemed colleagues. On that note, I will end and call to the podium Dr. Jonathan Hill, who will talk about the CTO anatomy and how to select your initial strategy. Dr. Jonathan.